now introduce Stephanie Price, who's Principal Lawyer at West Heidelberg Community Legal Service, to speak on Integrated Practice Makes Perfect.
Can I just clarify, mate? I'm solely using the clicker. I had a nightmare about this not working, so just the clicker. Okay, so I'm the Principal Lawyer at West Heidelberg Community Legal Service, which is a part of Banyule Community Health. Today what I want to do is describe some of the lessons learned from our experience of maintaining and developing, and at times refocusing and reinvigorating, what is a long-standing partnership between health and legal supports. So it's an integrated service model in the form of a health justice partnership, working with and in a community experiencing high and entrenched levels of disadvantage. So I'll draw in particular from a brief snapshot of some of the learnings of two recent projects implemented with the dual aims of achieving particular client outcomes, but also with the intention of reflecting on the barriers and enablers of integration and piloting new approaches to build meaningful and sustained connections between disciplines and teams. And I'll be looking mostly at the practitioner perspective. So these are the partners. Banyule Community Health is a mainstream standalone community health organisation. West Heidelberg Community Legal Service is a generalist community legal centre. In addition to the obvious difference between the organisations being one is a health service and one is a legal service, or the legal service is a program of the health service, the other substantial difference is the size of the two entities. So the community health service sees some thousands of patients per year, and the legal service sees between 500 and 700. And for the legal service, the majority of our priority client group are drawn from two suburbs within Banyule, and those are West Heidelberg and Belfield. So West Heidelberg Community Legal Service and Banyule Community Health have been were co-located from 1975 to 2014, and in 2014 merged to become a single entity, which is a unique organisational form for health justice partnerships in Australia. So these are some of the indicators of disadvantage in West Heidelberg and Belfield. So double the state unemployment rate, 10 times the state average of people living in public housing, a substantial call communities. You add to that things like criminal incidents occurring at 3 times the state rate. And West Heidelberg is, according to Victoria Legal Aid, a legal need hotspot. So it's in the top 10 legal need hotspots in Victoria, which means basically there's a lot of people with legal problems and a low capacity to deal with those. So we know from the experience of working within this community and from the research that people experiencing high levels of legal need will likely be impacted by multiple co-occurring and recurring legal needs. They will have poorer health outcomes. We know that their legal problems will be impacting on their health, and a classic example of this, and one that's absolutely pertinent to our community, is the example of mould in people's housing. So that's the second most common tenancy issue that people would come to us about. That's obviously a legal issue. That's a breach of a landlord's duty not to have mould in the premises, maintain the premises. But the effect of that is a range of health issues, in addition to research showing that people who are living in unsafe and inappropriate housing are much more likely to experience mental health issues. So we know that their health and social issues impact negatively on their capacity to identify and address their legal needs. And crucially, we know that only around 50% of people experiencing legal problems will actually seek help for those problems. And most of those who do won't seek a lawyer. They'll actually ask a trusted health professional for help. So I've always found the language of intersection, compounding, co-occurring as too neat a description of the experience of our clients dealing with their multiple problems. And the best definition that I've come across is that of Associate Professor Marianne Noon, and she actually, in relation to clients in West Heidelberg, this quote comes out of a study looking at our client base, but she describes their situations as being more like a ball tumbling around in a ball of problems, attempting to manage bit by bit. Sorry, and that picture was, I thought, a great representation of a ball of problems. It was actually an art piece gifted to me on my office wall by the child of one of my clients. So our problem statement, and it's certainly not unique to us, is how does a community-based service, and in particular the practitioners within it, act across disciplines to develop an integrated model of practice that's accessible and responsive to people tumbling around in a ball of problems. So the two projects that I'll run through briefly, one that was looking at housing and health outcomes. So the model was a collaboration, joint case management addressing legal and social needs between a lawyer and a social worker within the community legal service based within the community health service, so multiple layers of the sort of integration there. The contention of that project was that tenants are more likely to attend VCAT, which is the Victorian Civil and Administrative Tribunal. All states have a similar one. It's where you go if you have a dispute about your tenancy, and tenants across Australia avoid it like the plague. But our contention was that tenants would be more likely to go if they were receiving holistic support, and that if they went, they'd be more likely to obtain a positive outcome, and that positive outcome would likely make a contribution to their health. The second project is called Yarning Up Law, and it's working with the Aboriginal and Torres Strait Islander community. The model there is a partnership between the Aboriginal health team at Banyule Community Health and a project team within the legal service comprised of an Aboriginal engagement and community development worker and a lawyer. And the aim of that project is to improve Indigenous people's timely access to justice by integrating the offer of legal help with existing trusted spaces and services, so for example the local gathering place and other Aboriginal health team initiatives. So I won't address the service delivery activities that were part of the project. I'll skip quickly to the outcomes, just by way of indicating that it did work in the way that we hoped it would, but I'll actually then just move on to talk about the how of integration from our perspective. But just quickly, the housing project, the integration worked as we hoped it would, so most of our referrals came from workers within the health team. It was a successful early intervention approach, so 80% of the clients came to us before their problem had reached the VCAT stage, and 74% of the clients who were in the project turned up to VCAT with our support, and 70% of them were able to maintain their tenancy. Yarning Up has not concluded, so the outcomes at that one are halfway through the project. But at this stage, the indications are positive. Access has been improved, and we've had an increase in the numbers of Aboriginal and Torres Strait Islander clients accessing the legal service. The vast majority of those clients have obtained positive outcomes, and again, most of the referrals have come from within the health team. So as projects being implemented within an existing and indeed very long-standing health justice partnership, in delivering and evaluating these pilot approaches, we thought it was important to reflect on what existed really and some of the past barriers that might have been in place affecting integration in the service. So in that, we were able to turn to the scholarship of Associate Professor Marianne Noon, who I mentioned previously, who's written extensively about integrated practice, and because of the history of our service, has actually looked specifically at how it worked in our service. And so some of the sort of aspects of her work that we pulled out as being relevant to how we would design our interventions were, she found in a 2010 report that the connection between the legal service and the health service was uneven and heavily influenced by discipline. And this won't come as a surprise to anyone, but some disciplines are more inclined towards integrated service delivery than others. So she found that people connected with social workers and counsellors are more likely also to be connected into the legal service than those who are seeing the GP. The self-reported referral practices of the practitioners back this up. So, doctors and dentists indicated that they were less likely to make a referral than other workers. The small size of the legal service was an inhibitor to integration. It meant that there was an absence of dedicated roles for people to build connections across the service and engage in service-wide planning and improvement processes. And some staff had naturally more opportunities than others for cross-discipline contact. So to get to know the work of the other teams, to understand their perspectives and recognise opportunities to work together. So taking that work, we wanted to sort of delve a bit further into the perceptions of the health workers at the moment, and as part of the tenancy project, we surveyed, or we undertook sort of detailed interviews with some key health workers to see what the perspective was at the moment. And what they indicated was that the sort of categories of their perception as to the hurdles of integration fell into the following. So confusion about legal service intake and assessment procedures. So, what areas of law do we cover? What's our catchment? What and why are the intake requirements that you have different to the health service? There were indications that there were unmet expectations about the type of service that a client would receive. So people thought that a client would receive court representation, for instance, and what they got was advice. There was a lack of understanding about the reasons for the legal services' particular professional obligations. So, things like conflict checking a client before an appointment is booked in, confidentiality and privilege requirements, and client information barriers, which prevent the transmission of information from the legal service to other teams in the health service. But we were, as the outcomes of the project indicated, able to overcome these perceptions and build the relationships. And these are the sort of practical enablers in our experience of integration and really what we did. So we spent time on the relationships underpinning effective integration. The establishment and maintenance of relationships was built into our project plans, and in all cases we allowed many months for that. And at times, particularly at the start of the pilots, this could mean that we were spending more time engaging with the health workers than we were seeing clients, and that was fine. We had the flexibility with project funding and funders that were amenable to that as an important aspect of the project to dedicate that time. And I should say it was the Legal Services Board that funded both of these projects, and they understood that that was a critical aspect of the successful delivery. So we avoided saying no. We essentially accepted any and all referrals that came our way, quote unquote correct or not. So obviously establishing effective referral pathways isn't the end point of integration, but if you don't have that down pat, nothing else can flow from that. So we saw every attempt at a referral as an attempt at holistic service delivery and an opportunity for learning and capacity building amongst the workers. And particularly at the start of the project, as I say, we took everything that came our way and we built those relationships, and we're then able to, through those relationships, have those more detailed discussions about this is actually what we specialise in, and if this came to us in the future, this is the pathway we'd send that client on. Informal and formal collaboration across teams and disciplines. So, taking every opportunity you can to develop and work to achieve shared goals. So formally, that would be things like joint team meetings, community engagement activities, and law reform and systemic advocacy. Informally, an example in the Yarning Up project would be that it became apparent to us that playgroup facilitators from the Aboriginal supported playgroup were regularly bringing clients up to the legal service at the times of those playgroups. We hadn't planned for that or prepared for that, but in recognition of that reality, we then left that space free and essentially made it a sort of walk-up time, so we didn't book appointments. But that's not a formal aspect of the project, that's just informal recognition of the reality of the way that workers were engaging with our service. It was important to recognise and manage the potential for conflicting professional obligations regarding client support. So this meant having policies in place ahead of time that were, that recognise the respective frameworks that different practitioners can take to client support, and understood these at the outset. What we wanted to avoid was a situation where at the heat of the moment or a point of tension, workers are trying to work out whose obligation wins, essentially. So, having those policies in place was certainly an important aspect of that. And related to that is developing a collegiate culture based on mutual respect. And we also took the view that part of our role was, explaining, sharing our professional experience with key healthcare workers, and in their minds reframing some of our obligations to being from, what can be perceived to be barriers to clients accessing services, to really an understanding that Some of the obligations lawyers have around conflict checking and legal professional privilege are really aspects of clients' rights. So they're in order to facilitate clients' engagement with legal assistance. And we had to develop strategies to celebrate examples of effective integration in our service without sharing information across the service. And that was one of the particularly important learnings. So, I mean, in conclusion, they all come in the one door. That's an indication of the sort of foundation of our integration being the services being in the one place and located within the community. But certainly that's only the start for us. Integration, is an ongoing journey. It's not an endpoint, and it requires deliberate and sustained effort. So that's it. I don't have a thing with my details on it, sorry.
Before you leave, we'll take one question. We're out of time, but let's sneak one question in if there is one from a different questioner. And if there aren't any, thank you. Oh, yep.
Can I just ask a very quick question? From the point of view of the health professionals, did they see a change, or how did they acknowledge that involvement? What did they say?
I mean, we went back and surveyed them after the conclusion of the tenancy project, the same workers that we'd surveyed at the start, and the indication was that the service has vastly improved, and we feel like we can refer now, and we're happy with the outcomes for our clients. Obviously, the caveat to that is we're a small service, so it was the same person interviewing them at the start as at the end. So it's not a rigorous evidence base, but certainly the outcomes that we have following on from those projects indicate that the integration at the service is in a really healthy place.
Thank you.